If you're unsuccessful and you're having frequent gout attacks, those are the patients that end up developing actual joint damage, not only inflammation in the joint, but you can really damage your joint with multiple attacks of gout and accumulation of crystals in the joint and tophi in the joint.
So a person who wanted to figure out which foods they might want to avoid should look up which foods are high in purines. Is that right?
Purines, yeah. And you can, if you Google, a gout diet, it'll give you a list of the 10 foods that are the highest in purine content, and throw alcohol in that group, and then you have a very good pathway to reducing that in your diet and hopefully controlling it without medications.
Great. We have had some listeners tell us that cherries, drinking cherry juice or eating cherries actually was helpful, and there is some research suggesting it might lower uric acid. Is this worth pursuing?
Well, I think cherries, there are a few studies that show a beneficial effect, and my understanding of that literature is that there may be some anti-inflammatory properties of the cherry, and there may be a, quote, anti-inflammatory diet, and that's probably where that originates. I don't routinely recommend that in my practice, however.
So, Dr. Diehl, your overall perspective on uric acid levels, gout, if someone is, for example, taking a blood pressure pill that has a diuretic in it and they start to feel some joint pain and maybe even have a little ache in that big toe, should they ask their doctor for a uric acid level?
I think that's a reasonable thing to do, yeah, absolutely. And if it's high and if they're symptoms, some people won't have a massive attack the first time. Some people have these petite attacks where they have aches and pains in the joint before they'll have a massive attack. So that may be prodromal symptom to gout, and I think it's worth evaluating with a uric acid level and making some alterations in either the diet or the medication.
Dr. Chad Diehl, thank you so much for telling us all about gout today on the People's Pharmacy.
Thanks, you're welcome.
You've been listening to Dr. Chad Diehl. He's head of the Center for Osteoporosis and Metabolic Bone Disease at the Cleveland Clinic. He's a board-certified rheumatologist.
And remember what Dr. Diehl said, if you're taking a blood pressure pill, there's a good possibility there's a diuretic in there. And if your big toe starts to hurt, ask your doctor to test you for uric acid levels. After the break, we'll talk about an embarrassing situation. Have you ever lifted something heavy and leaked a little?
Urologists classify leaks as due to stress or urgency incontinence. What's the difference?
How are these two types of problems treated?
We'll discuss the pros and cons of surgery and medications.
What's a non-drug treatment that could be helpful?
You're listening to the People's Pharmacy with Joe and Terry Graydon.
This People's Pharmacy podcast is brought to you in part by Verisana.com.
Verisana Lab offers home health tests that allow you to monitor your hormones and health conditions. You can take control of the quantitative assessment of your health and learn about male and female hormone balance, the stress hormone cortisol, leaky gut, gluten intolerance, or your gut microbiome.
Take a more active role in tracking your health and take 20% off your first order of a mail-in testing opportunity with the discount code PEOPLE. That's uppercase PEOPLE. To learn more, go to Verisana.com. That's Verisana.com. Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. If you would like to purchase a CD of today's show or any other People's Pharmacy episode, you can call 800-732-2334. Today's show is number 1172. The number again, 800-732-2334. 2334, or find it online at peoplespharmacy.com. You can also download the free podcast from Apple, Stitcher, or our web store. We invite you to consider writing a review.
The People's Pharmacy is brought to you in part by Kayabiotics, probiotic products made in Germany from certified organic ingredients. KAYABiotics.com.
We're talking today about some common problems that aren't discussed very often. One that's rarely mentioned is urinary incontinence. It's embarrassing to talk about it. But it isn't just an old lady's problem. Young women may also find they pee involuntarily when they sneeze or laugh too hard. What can you do about it?
Our guest is Dr. Peter Jepsen. He's Division Director of Urogynecology at University of New Mexico. He's board certified in both obstetrics and gynecology and female pelvic medicine and reconstructive surgery.
Dr. Peter Jepsen, welcome to the People's Pharmacy.
Hello. It's great to talk to you today.
Dr. Peter Jepsen, you're the senior author of a recent study in which researchers looked at a variety of treatments for stress and urgency urinary incontinence. First, can you tell us how common this condition is and what is it exactly? How do you define, for example, stress incontinence?
Certainly. Urinary incontinence is a very common condition. It affects about 1 in 5 women, so roughly 20%. Incontinence can be divided into different subcategories, such as stress incontinence or urgency. Stress incontinence is the leakage of urine with laughing, coughing, sneezing, jumping, exercise, anything that increases intra-abdominal pressure. Urgency incontinence is more of that sensation of gotta go right now, and it's a strong urge that is difficult to defer and will, for many women, will often result in leakage. Urgency tends to be larger volume leakage, so it tends to be quite a bit more. Stress incontinence tends to be more drops and tends to be more predictable. You can feel a sneeze coming on or know that if you're going to laugh or something that you'll have a little leakage. So that's kind of a little background on those.
Well, I appreciate you explaining the difference between them. How are they treated differently?
So there are treatments that overlap for both. So in the systematic review we recently did, we kind of categorized all non-surgical treatments essentially. But for both stress incontinence and urgency incontinence, behavioral therapies such as timed voids or Kegel exercises, strengthening the muscles of the pelvic floor, those have been shown to be beneficial for both types of incontinence. However, there are differences as well. Stress incontinence is thought to be a weakening or a defect, if you will, of the urethra in that it's not able to maintain urine within the bladder. So there are support devices or things that could be placed inside the vagina to offer support to the urethra to prevent leakage. Whereas for urgency incontinence, it's thought to be more related to muscle spasms of the bladder wall itself. And so there are medications and other interventions specific to bladder spasticity that will hopefully decrease those spasms to decrease leakage.
Dr. Jepsen, I suspect that a lot of people, when they hear the word incontinence, they think old people, somebody who's over the age of 60 or even 70.
And it is a problem for older people, for sure.
But not everyone. Even some younger people can experience stress incontinence. Am I right?
That is certainly correct. It is a problem that becomes more common with age for both types, both stress and urgency. Stress incontinence does tend to present a little bit earlier, though. For women who are active, exercising, those types of things, they'll often present in their 40s. Urgency tends to be a little bit later in life, but it can happen as early as teens or 20s for either type. But again, it is very common, and pregnancy, deliveries, those types of things are often an inciting event for many women.
Now, there are a couple of what I'll call controversial treatments, and one that's been used for decades has to do with surgical mesh, synthetic mesh, that I suspect you and your colleagues have used for quite a long time. The Food and Drug Administration just said, no more. Mesh is out of there when it comes to transvaginal treatment of what's called prolapse. So can you tell us what the problem was with mesh and what you can do instead, especially non-drug approaches?
Certainly. So, as far as mesh goes, and to back up a little bit, we've been talking a little bit about urinary incontinence. The FDA ban is specific to mesh used for prolapse and placed transvaginally. Kind of historically, prolapse is when the vagina everts or kind of falls out and starts coming outside of a woman's body. There are many different treatment options, non-surgical as well as surgical treatments for that. The non-mesh based procedures use stitches and a woman's natural or native tissue for repair. Those repairs have not been as durable as we would like, and so because of that, mesh was started to be used for prolapse repair. When mesh is used, the repairs are more durable. Somewhere around 90% or so of women who have a mesh augmented repair will not have recurrence of prolapse. The downside to mesh is that mesh can cause problems, pain, bleeding, erosions. Mesh can end up either in the vagina or in the bladder or other places that it is not supposed to be. Mesh for bladder use is primarily founded upon the mesh that was used for abdominal hernia repairs. And in the early 2000s, there were many different types of transvaginal mesh procedures that were done. And as data emerged, it showed that the complications may outweigh the risks. I'd like to point out that as far as the FDA mesh ban goes, it is specific to mesh used for vaginal prolapse. They did not ban the use of mesh for urinary incontinence. There are mesh procedures that can be done for stress incontinence that have been shown to be quite effective. That is not to say they don't have complications, but the complications in general are rare. Most are less than 2 or 3%, and many of the bad outcomes are less than 1%. For stress incontinence, the most national and international organizations still consider it the gold standard treatment for surgical therapy of stress urinary incontinence, and that's based on many, many studies that have been published in the New England Journal and lots of other places. But the FDA ban on transvaginal mesh for prolapse is, I think it is big news. So I don't know if that's going to be a permanent thing, if they're waiting on more research. I know that there are a couple of NIH-funded studies looking specifically at certain vaginal meshes, and I don't know when that data comes out, if that would change the ban or if the ban is permanent. But certainly there can be complications with the placement of transvaginal mesh for prolapse.
Dr. Jepson, there have been many commercials on television encouraging women to ask their doctor about a medication for what appears to be either stress or urge incontinence. And these are mostly what we refer to as anticholinergic drugs. Can you tell us, how effective they are and what the downsides are? We've been hearing a lot about anticholinergic load and its effect on memory and the central nervous system, the brain.
Certainly. So, as far as anticholinergics, those are typically considered a treatment option for urgency incontinence. They're kind of antispasmodics or anti-bladder spasm medications. They are effective, but they require daily dosing. It's something you'd have to take a pill every day, and if you stop taking the medication, it stops being effective. Studies show that only about 50% of women who start an anticholinergic medication will still be using it at 3 to 6 months. And part of that is due to efficacy, and part of it is due to side effects. Common side effects of anticholinergic medications are dry eyes, dry mouth, constipation, but cognitive changes have been associated with anticholinergic medication, and that's not specific to the medications used for the bladder, but as you mentioned, the anticholinergic load. If patients are using anticholinergics, for different reasons, and many different medications fall in these categories, the overall burden or load can certainly contribute to that. that. There is thought to